Welcome to Fertility and Sterility on Air, the podcast where you can stay current on the latest global research in the field of reproductive medicine. This podcast brings you an overview of this month's journal, in-depth discussion with authors, and other special features. F&S On Air is brought to you by the Fertility and Sterility family of journals in conjunction with the American Society for Reproductive Medicine.
Hi, and welcome to another episode of F&S Unplugged. I'm your co-host, Pietro Bortoletto, and as always, I'm joined by Daylon James and Blake Evans. Daylon and Blake, how are you two?
Very well, fellas. Very nice to be with you today.
I am doing fantastic. It is so great to see you all as usual.
You'll notice that the strongest member of our team is not with us today, Dr. Molly Siegel-Cornfield. So special shout out to Molly if you're listening to this on the back end. We miss you. But we have lots of good science to talk about today. So we're starting off with a non-traditional review article from F&S Reviews today. We're looking at current options to lower the cost of IVF. You may be wondering, man, IVF is expensive. I wish I lived in a mandated state like I do in Massachusetts. But for a lot of patients, they're paying out of pocket, and figuring out how to save money. Treatment add-ons, I think, is always a benefit and something that should be increasingly more cost conscious about. This paper is a wonderful one from my friend, Dr. Bruce Pyre, but I'm going to let my other friend, Dr. Blake Evans, tell you a little bit more about it.
Thank you so much, Pietro. So the title of this paper from F&S Reviews this month is Current Options to Lower the Cost of In Vitro Fertilization, a Comprehensive Review. First author is Austin Gardner at UAB, and senior author, as you'd mentioned, Dr. Bruce Pyre at the Madigan Army Medical Center. So although there is an increasing number of patients that seek infertility treatments, their services can be difficult to access, largely due to cost and or lack of coverage. So I did the liberty of looking at the SART.org website for some general numbers, and the numbers of all cycles of initiated egg collection has increased from about 90,000 in 2004 to 150,000 to 2019. And even with coverage, patients are left making difficult choices who need additional IVF cycles, because often the coverage can be capped when they do have coverage. So because of this, cost causes many couples to prematurely quit IVF cycles or pursue cheaper options. And these financial strains cause some patients to feel the need to risk multiple gestation pregnancies to, quote unquote, improve their chances and minimize the total number of cycles that they need to undergo. This is a thought process that I almost daily have to explain to patients, that more embryos doesn't really improve live birth rates overall, particularly in the younger patient population. And not to mention all the medical complications, hospital bills, and even just the cost of multiples throughout their life is way more money than the patient would ever pay for an IVF cycle. And so this review focuses on the methods that may lower cost of IVF, but also interventions needed in areas of awareness. This was a literature search that was conducted assessing over 100 manuscripts that all discuss low-cost IVF with regards to models for IVF funding, laboratory factors, IVF stimulation, lab and or medication cost, and also personalized approaches that may reduce cost. So I'm going to elaborate on each of these categories and what they found. So looking first at current models for IVF funding, the first state to enact mandated insurance coverage was, can either of you guys guess? What was the first state to mandate coverage? You got 3 seconds. No? You guys aren't going to guess? Paige, you're even listening right now?
I'm guessing.
I'm letting Daylon
Alaska.
take a crack at it.
I'm saying Hawaii.
I'm going to go with Oklahoma, Blake Evans' home state.
No, unfortunately, not Oklahoma. Maryland. In the 1980s, Maryland was the first state. Several states have followed. Sadly, not Oklahoma has not followed where I'm at. And this has shown an increase in the usage of IVF and overall the decrease in the mean number of embryos transferred. So again, look back at some SART data showing that over the course of about 20 years, the average number of embryos transferred in someone less than 35 was about 2 to 3 20 years ago. And now is about 1, fortunately. And the twin risk has decreased from about 27% to 5%. There are a few factors that, of course, go into this number, but a lot of it is coverage for IVF. So although mandates exist, there's still several exclusions that apply. For example, small businesses are excluded from coverage in these mandated states. And believe it or not, a patient's BMI, which was surprising to me, I did not realize that. So despite infertility being recognized as a basic health need, still the majority of states and insurance companies do not provide coverage of IVF, and is a major determinant of proceeding with care. The authors also looked at laboratory factors. So laboratory costs are about 50% of a total cycle cost. The authors discuss a few factors that can potentially reduce these costs. So for one, not overutilizing ICSI for non-male factor infertility. Another thing that they looked at is going straight to IVF or ICSI for those with a varicocele or obstructive azoospermia is not necessarily cost effective for all patients. And this is something to be considered. They also discuss the implementation or utilization of intravaginal culture. This is where a patient places a small incubation chamber vaginally containing the sperm and the oocytes rather than utilize the IVF lab cost. This is a currently utilized technology. However, its data are conflicting regarding its efficacy compared to conventional IVF. And the published data on cost comparison are not existent as discussed by the authors. Another thing that the authors mention is the utilization of PGTA. This is something that's not cost effective for all patients, but may be cost effective for carefully selected RPL patients or those with advanced reproductive age. They also talk about IVF stimulation. They discuss a couple of things to consider, such as natural cycle IVF or minimal stimulation IVF. The benefits that they discuss with natural cycle IVF is that it might provide a lower cost and lower OHSS risk, although at a lower clinical ongoing pregnancy rate per cycle. And yes, these patients may pay much less due to fewer medications, but the need for multiple egg retrievals to get pregnant and all of the inherent risk that is associated with each egg retrieval, such as anesthesia, risk to surrounding structures within the pelvis, etc., compared to just one egg retrieval for standard IVF is certainly something to consider. And they talk about minimal IVF, or also known as low intensity IVF stimulation, or considerations as well. This is, for example, when you take oral agents like Clomid or Femara, plus or minus a low dose gonadotropin. And they talk about how this can potentially lower cost savings, particularly for patients with diminished ovarian reserve that may have achieved a very similar response if you were to just dump gonadotropins into their body in very, very high doses. So that's also something that they consider. The next area that they look at is laboratory and medication costs. There are some studies that support doing ultrasound only. So for example, you only do one blood draw the day of trigger shot, but otherwise you don't get any blood draws throughout the IVF stem cycle. And there are some studies that support that there's similar outcomes when you do this, believe it or not. And then another medication cost savings, and Pietro, you and I have talked about this before and done this to some degree, but use of oral progestin agents such as medroxyprogesterone acetate rather than GnRH antagonists for pituitary suppression. So as I mentioned, I've done this a couple of times. Pietro, I know you have as well. I know that we talked earlier about shameless plugs for ourselves in this podcast, but I will say I did do a cost analysis on this subject when I was a fellow. And we found that about if you're planning for a freeze all cycle, not a fresh transfer, then it saves about $2,000 if you utilize medroxyprogesterone acetate to suppress LH surge instead of GnRH antagonists. So certainly something to consider. And then the last couple of topics they look at is unexplained infertility. They mentioned the coveted study that we all know, the Reindaler et al. Study, or the FAST study from F&S in 2010, where it looks at the lower cost per delivery of about $10,000 if you go straight from ovarian stimulation and IUI to IVF and skipping doing 3 cycles of FSH and IUI in between. We also know now that gonadotropin cycles come with a very high risk of multiples with no overall improvement in success rates. I mean, this is not considered a recommended therapy in patients with unexplained infertility. There are actually several other things that the authors discuss, and for the sake of time, I'm not going to go over all of them, but as always, I recommend our listeners to go back and read through the study, but they do delve into other topics such as obesity before undergoing IVF, PCOS patients before they undergo IVF, tubal reanastomosis compared to IVF in regards to patient age, oral adjuvants for diminished ovarian reserve such as CoQ10, DHEA, and growth hormone, and also polypectomy before IVF. So in conclusion, the authors discuss how that there are several states lacking coverage for IVF, and patients may not be able to proceed with this treatment or may terminate treatment prematurely because of financial barriers. Approaches involving minimal stem, efficient or alternative drug administration, and alternative medication preparations may provide reduced cost and possibly similar outcome results with conventional IVF. And lastly, personalized approaches to medication dosing and procedure selection on the basis of specific infertility diagnoses may reduce IVF treatment cost and lead to more efficient cycles. So, as always with these review papers, a lot of info to unpack, but I really thought this was a nice, thought-provoking paper. And of course, as I mentioned earlier, I live in a non-mandated state, so my patients are actually very commonly asking these questions and very commonly seeking out, you'll talk with them too about traveling long distances or going to clinics, because there are clinics out there that recognize that IVF is so expensive, and they will promote themselves as having a quote unquote lower cost, but then you get in their door and then they'll have you pay tons of money on medications or IV infusions that don't have evidence to back them up, and then ultimately hike up the price of what you pay anyway. So very interesting paper. What do you guys think about it?
Well, let me ask first, as someone who obviously doesn't have a foot in the clinic, I would ask you guys where we're trending, right? Because to me, where there's a lot of maybes in terms of how this could improve or lower the barrier cost there, and they're all great ideas, and I applaud the authors. I just wonder, like, if we do a reality check here, there's global factors here, which I would say the high demand, unmet demand, which is only increasing, and also the rise of the kind of commercial or storefront type medicine apparatus and integration with assisted reproduction. So I would ask you, given those overarching influences and the whole, capitalist commercial, I think, major influence there, where do you think we're trending? Are we trending towards lower costs because we're improving, the efficiency of the procedures, or are we staying at the same cost and just, getting a lot more volume?
I think where there's two forks that are kind of moving forward, there's definitely a small contingent of reproductive endocrinologists that I think are adding things on to cycles